Hello, thank you for having me. My name is Dr. Mezu-Ndubuisi. I am an Associate Professor of Pediatrics and Ophthalmology at the University of Rochester, New York. The title of my talk is In Vivo Retinal Imaging, a Window to Understanding Neonatal Diseases of Abnormal Vascularization Beyond Retinopathy of Prematurity. I have nothing to disclose. Today, we will review risk factors, pathogenesis, and clinical management of ROP. Then, we will discuss in vivo retinal imaging methods in ROP and comparative histopathological findings, and review potential new therapies for ROP and their clinical translational implications. Finally, we will highlight the use of in vivo retinal imaging to study other neonatal diseases in mouse models and look at future research directions. Don't you love spring with the colorful cherry blossoms and butterflies? To appreciate the beauty of spring in full color and depth, one requires good vision, which is truly a complex process. Light rays from the butterfly on the cherry blossom enter the eye and pass through an optically clear medium with refraction on the cornea, then the lens, to come to a point focus on the retina, the innermost layer of the eye, and from there visual impulse is propagated to the occipital lobe. The retina is not a flat tissue. Light rays go through the 10 layers of the retina to the photoreceptors, rods and cones, and convert the light signal into a photochemical signal that initiates a signal transduction through a series of synapses from the bipolar cells to the ganglion cells. The ganglion cell axons make up the optic nerve fibers, which become the optic tract that crosses at the optic chiasma to become optic radiation and carry information to the brain to interpret color, depth, form, and the position of that butterfly on the cherry blossom. ROP is a condition of abnormal retinal vascularization in premature infants exposed to supplemental oxygen with a significant global impact. There is no known cure for ROP, and it remains a leading cause of avoidable childhood blindness worldwide. ROP incidence has increased in severity in infants of younger gestational ages and lowest birth rates, less than 1,000 grams. This map shows the 2010 economic and geographic distribution of the estimated number of children with severe visual impairment and blindness from ROP. While the incidence and the risk of blindness appears equivalent, about 2% among lower, middle, and high-income countries, a closer look at total preterm births at less than 32 weeks gestation at risk for ROP worldwide shows that sub-Saharan Africa has the lowest number due to poor survival from lack of resources and limitations in care, compared to middle-income countries of Asia, Latin America, Middle East, and Eastern Europe with increasing access to neonatal intensive care. The lowest number of children born blind are seen in high-income countries with advanced perinatal and postnatal technologies. Now let's talk about retinal vascular development. The retinal vessels develop by the process of vasculagenesis, where primordial vascular cords form the superficial retinal plexus, and later by angiogenesis, where vessels form from existing vessels to populate the deep retinal plexus. Retinal vascularization starts in utero at about 16 weeks gestation from the optic nerve outwards. The nasal retina is vascularized at 36 weeks and the temporal retina by 40 weeks. Prematurity disrupts vessel growth, creating an avascular retinal periphery. So, what is the pathogenesis of ROP? In utero, hypoxia drives angiogenesis in the developing retina. With preterm birth, the infant is now cut off from placental and amniotic fluid proteins and growth factors like insulin growth factor 1 and vascular endothelial growth factor VEGF. The infant is now exposed to a hyperoxic ex utero environment. Hyperoxia disrupts angiogenesis, exacerbated by supplemental oxygen given to premature infants for their long immaturity, causing oxidative stress and release of free radicals which injure the retina, leading to ROP. ROP progresses in two phases. Phase 1 occurs shortly after birth in high oxygen, which downregulates VEGF expression, leading to vaso-obliteration. 4 to 6 weeks later, there are now not enough blood vessels to nourish the eye and the retina, and hypoxia develops, which causes excess secretion of VEGF, leading to phase 2 ROP, characterized by pathologic neovascularization, bleeding, fibrosis, and retinal detachment. Other risk factors for ROP include inadequate postnatal nutrition. It is always a challenge to provide enough calories for growth in preterm infants. In addition, they have a deficient antioxidant system and may have infections and inflammation. Now to the clinical classification of ROP. Zones refer to the area of vascularization relative to the optic disc. Zone 1 is a concentric circle centered around the optic disc and 2 disc diameters temporally to include the macula, which is the point of sharpest vision and color vision. Zone 2 is a concentric ring around Zone 1 extending from Zone 1 to the nasal peripheral retina. Zone 3 is the remaining crescent-shaped area on the temporal retina, as we can see. Now, the stages of ROP refer to the vessel appearance at the vascular-avascular interface. In stage 1, a demarcation line appears at that vascular-avascular interface. In stage 2, a fibrovascular ridge forms at that interface. In stage 3, pathologic neovascularization or extraretinal fibrovascular proliferation forms at the ridge. Plus disease or engorgement and tortuosity of the retinal blood vessels near the optic disc is a powerful indicator of severe ROP activity. Stage 4 would be partial retinal detachment, and stage 5 would be total retinal detachment. I love this schematic showing ROP clinical pathogenesis as well as physiologic changes in VEGF levels. In utero, physiologic hypoxia and normal VEGF levels promote vascular growth. Premature birth into a high oxygen environment initiates ROP because high oxygen downregulates VEGF. Dilated fundus exam for ROP begin at about 31 weeks postmenstrual age or 4 to 6 weeks after birth. As the infant matures, hypoxia occurs and low oxygen upregulates VEGF, leading to ROP progression. If there is no treatment, it could progress to retinal detachment. Treatment goals here have been to reduce the angiogenic stimuli from the avascular periphery in order to decrease VEGF levels. Treatment has advanced from cryotherapy in the 1980s with its poor structural outcomes to laser therapy in the 1990s with peripheral deficits, and laser therapy remains the current standard of care. In the past decade or so, bevacizumab, an anti-VEGF monoclonal antibody, has emerged as an adjunct or an alternative to laser therapy in phase 2 ROP. Avastin and other anti-VEGF drugs are the main pharmacologic therapy for ROP. Potential risks of anti-VEGF therapy include systemic absorption, and there is non-selective blocking of all VEGF isoforms, and this poses significant risks to developing organs like the lungs, brain, liver, and kidneys that do need VEGF for vessel growth. ROP was a prospective, randomized controlled landmark study published in New England Journal of Medicine in 2011 comparing laser therapy with bevacizumab. These photos and corresponding angiograms show infants with stage 3 zone 1 ROP. Figure A shows the retina in an X24 weeker before laser therapy at 33 weeks postmenstrual age. And figure B was taken in the same infant at 13 months PMA, showing full thickness destruction of the peripheral retina with the underlying choroidal vessels visible. Image C shows the retina of an X23 weeker at 35 weeks PMA before intravitreal bevacizumab therapy, and image D shows the retina post-treatment at 13 months PMA with continued peripheral retinal vascularization. This shows trends in ROP screening and treatment from 2008 to 2018 in a cohort of over 380,000 very low birth weight infants from about 819 U.S. NICUs that are participating in the Vermont-Oxford network. From 2008 to 2018, there were significant decreases in the incidence of ROP of any stage from stages 1 through 5 and severe ROP stages 3 to 5, likely due to improvements in perinatal and neonatal care. We can see that over time, less retinal ablation was performed and more anti-VEGF treatment was used. It is interesting to note in the study that despite increased ROP screening over time, from 89% in 2008 to 91% in 2018, about 10% of infants were not screened. And so this does represent an opportunity for improvement in healthcare delivery. Why is this important? This is because of the long-term visual outcomes from ROP, which include strabismus, color vision deficits, high refractive error, amblyopia, and increased risk of glaucoma. These are seen in decrease in severity in infants with severe treated ROP, those with mild regressed ROP, as well as premature infants without ROP and some full-term infants, pointing to an early developmental process. This raises concerns about additional mechanisms beyond abnormal vascularization. This brings us to the current concerns about clinical ROP. While increasing number of premature births have been going on, there is also an increasing burden of ROP screening, overwhelming the limited number of ophthalmologists with additional stresses of dilated exams on their often critically ill premature infants. The lack of a standardized objective method of diagnosing ROP severity has challenged its use clinically and in research trials. Current ROP treatments are limited in efficacy and have systemic adverse effects. So, my goal when I started research was to use lab research to better understand the pathogenesis and mechanisms of ROP as a guide to developing safer, more effective therapies in order to improve the neurodevelopmental outcomes of babies. This led me to several clinical questions. Is ROP just a vascular disease? I asked this question quite early in my second fellowship training at UIC Chicago about 12 years ago. We all know that the oxygen given to premature infants is delivered directly to the lungs, either invasively via an endotracheal tube or non-invasively through different nasal cannula interfaces, but the effects are seen distally in the retina. So I believed that hyperoxia initiates a systemic inflammation propagated through blood vessels to the retina, and that the entire retinal tissue will be affected, and not just the vessels. I set to find out using an animal model. The retinas of newborn mice vascularized postnatally, making the mouse OR model ideal to study ROP. So my hypothesis was that ROP affects retinal vascularization, structure, and function, and this could be studied in vivo without killing the mouse. Next, I asked the question, how much oxygen is too much? We don't know. Oxygen is a drug and should be used judiciously, only as much as needed to maintain optimal lung function and retinal oxygenation without toxicity. I first wanted to determine how much oxygen caused retinal damage in OR mice. There was no one doing ROP research, so I collaborated with Dr. Shahidi, whose expertise was studying vascular oxygen tension in rat models of adult retinal diseases. Using a retinal imaging system, we did fluorescein angiography from postnatal day P17 to P19. Due to the limited 30-degree field of view, we created a montage image from different quadrants. The Romer raised mice or controls had uniform retinal vasculature, while the oxygen-exposed OIR mice had avascular areas between major vessels. To measure oxygen tension, a molecular probe PD-porphyrin was injected by tongue vein, and this emits phosphorescence light, which is quenched by oxygen. The phosphorescence lifetimes were calculated and converted into vascular PO2s presented as a color map. The vessel with the highest oxygen content there was taken to be the artery in red, and the vessels with the lowest oxygen content were taken to be the veins in blue. AV difference PO2 was higher in OIR mice than Romaine mice, as now fewer vessels supplied a larger retinal area, leading to increased oxygen extraction from the underlying hypoxic retina. So, my new lab at UW in 2014 utilized a retinal imaging system that allowed a large view of the retina. We used a modification of the existing mouse model of OIR by Dr. Lewis Smith. The mouse at newborn is equivalent in gestational maturity to a 24-week-old infant, and both undergo postnatal retinal development. The newborn mice were separated into two groups, one raised in Romer, and the other group was exposed to 77% oxygen from postnatal day 7 to P12 to simulate vasobliteration, and then returned to Romer to simulate relative hypoxia. Then, from P16, we began in vivo imaging. First, the mice were anesthetized. Their pupils were dilated and fluorescein injected intraperitoneally to visualize the vessels. FA was done within 1 to 2 minutes. In FA images, one could clearly see the difference between the fully vascularized capillary network and normal caliber vessels of the Romer mice and the avascular network of OIR mice with tortuous arteries, dilated veins, and sometimes AV shunts develop due to the underlying hypoxic retina. I went on to study these FA changes throughout developmental maturity of the mouse. I developed a customized MATLAB program with bioinformatic experts, which I've made publicly available at quantbv.com. This software has been used by other researchers for vascular quantitation in retina beyond ROP, as well as systemic disease. With QuantBV, I was able to group these changes into phases. Early phase, P16 to P20, showed increased capillary avascularity, dilated veins, and tortuous arteries in the OIR mice compared to Romer at every age, but there was no significant difference within groups in this age. Mid-phase from P23 to P27 showed some recovery of abnormal vascular features, and late phase from P30 to P34 showed full peripheral vascular coverage, normal vein width, but persistent arterial tortuosity. Percent retinal vascular area showed the greatest difference between OIR and Romer mice in the early phase. Retinal vein width was wider in OIR mice in early phase too. However, retinal artery tortuosity was markedly increased in OIR mice in each phase studied, so arterial tortuosity may be a more reliable marker of OIR recovery or severity. I then collaborated with Dr. Shibani's lab to prepare retina whole mounts in the Romer and OIR mice to assess vaso-obliteration and neovascularization in comparison to a live retinal vascular imaging. In the Romer mice, there were no quantifiable areas of vaso-obliteration and neovascularization, while the OIR mice showed decrease in areas of vaso-obliteration and neovascularization with advancing age. The mature phase comprised adult mice older than P35. A closer look at the capillary network using in vivo imaging showed that the neovascular buds were present in Romer mice, but clearly absent in OIR mice. This differs from existing literature reports that the OIR mice recover completely between P21 and P25. Our in vivo imaging shows that despite the full revascularization in OIR mice, there is permanently reduced angiogenic activity from just 5 days of hyperoxia exposure. I wondered why. What could this mean for premature infants exposed to high FiO2 for weeks and months? Using one age to represent each phase, we next explored the effect of OIR on retinal structure with in vivo spectral domain optical coherence tomography following FA. We showed that OIR mice had reduced total retinal thickness compared to Romer mice. However, the outer retinas of OIR and Romer mice had similar thickness. Rather, it was the inner retinas of the OIR mice that were thinner than those of Romer. We further explored the functional changes in OIR retina using focal electroretinogram ERG in a region of interest 2 disc diameters from the optic nerve head, shown by the red circle. The A-wave signal generated from the outer retina and the time to A-wave were similar in OIR and Romer mice. The B-wave generated from the inner retina was similar in both groups, but the time to B-wave was prolonged in OIR mice, indicating abnormalities in postreceptor signaling. The inner retina appeared to have a delayed reception of signals from the outer retina or a delay in generation of signals within the inner retina. We began to wonder if capillary attrition was related to inner retinal thinning and dysfunction. So we decided to take a closer look at a slice of retinal histology to study not only vessels, but the cellular content of the retinal layers and how they are affected by oxidative stress. Retinal vessels develop concurrently with maturation of the retinal neurons and glial cells. I love this figure because it shows the intricate relationship between retinal neurons, capillaries, and glial cells. Retinal microglia and macroglia, which consist of astrocytes and Mueller cells, provide a supporting network of retinal neurons and serve as a scaffolding guide to developing retinal vessels. They also survey the retina for potential injury or infection. Retinal glial cells become activated during injury or stress and can either support neuronal survival or they can accelerate neuronal degeneration. How long glial activation lasts and its effect on the retina in ROP is relatively unknown. We decided to find out. In addition to showing increased apoptosis in OR mice compared to rumen mice, we did that through a tunnel staining. We also performed immunohistochemical staining for glial fibrillary acidic protein GFAP in retinal cross-sections to check activation of retinal microglia, your astrocytes and Mueller cells. GFAP positive astrocytes were seen in the nerve fiber layer just below the inner limiting membrane and were increased in OR mice compared to rumen mice. The Mueller cells span the entire retinal cross-section from the inner limiting to the outer limiting membrane. It is interesting to note here that there were no GFAP positive Mueller cells in rumen mice, but there was increased GFAP staining in OR mice with a peak at P32, persistent until P47 in the adult OR mice. We next stained the retinas with ionized calcium binding adapter molecule 1 IBA1 antibody and showed prolonged microglia activity in OR mice. There was an increase in the number of total and activated microglia in OR retina at all ages compared to rumen mice, with decrease in severity but persistent even at P47. Microglia staining was most prominent in the inner retina, especially the ganglion cell layer, particularly at P19. We then took a closer look at retinal neuronal synapses between the photoreceptor cells stained green with postsynaptic density protein PSD95 and rod bipolar cells stained red with protein kinase C alpha PKC alpha. We found that rumen mice had uniformly aligned synapses, but OR mice had malaligned or ectopic synapses. The white arrowheads show the ectopic synapses extended beyond the outer plexiform layer to the outer nuclear layer. The graph shows that there are more abnormal synapses in the peripheral retina compared to central retina. Since VEGF is the most implicated growth factor in ROP pathogenesis, a study of mechanisms should involve an enhanced understanding of VEGF dysregulation in ROP. This, I believe, will be vital to developing effective therapies to preserve vision in this vulnerable population. However, VEGF is a very complex protein with several subtypes in the family, namely VEGF A, B, C, D, E, and F, with VEGF A being the most predominant in the eye. VEGF ligands have complex interactions with tyrosine kinase receptors, VEGF receptor 1, 2, and 3. VEGF mRNA undergoes alternative splicing at exon 8 to generate 5 homodimeric isoforms. Human VEGF proteins are one residue longer at 165 than the murine VEGF 164. VEGF A165 can be spliced proximally to become pro-angiogenic VEGF A165A or distally to produce anti-angiogenic isoform VEGF A165B. However, the precise role of VEGF-A splice variants during OIR is unknown. Using PCR in rumen OIR mice, we found increased VEGF A164 isoforms and VEGF receptor 1 expression in phase 2 OIR. Going from P10, the peak of vasobliteration, to P16, VEGF A164A and A164B expression increased in both OIR and rumen mice. However, at P16 in OIR mice, anti-angiogenic VEGF A164B was expressed slightly higher. VEGF receptor 1 was increased at P16 compared to P10 in both rumen and OIR mice. VEGF receptor 2 remained unchanged in both rumen and OIR mice. At P13, VEGF receptor 1 was expressed slightly higher in OIR mice, while VEGF receptor 2 trended higher in rumen mice. So you can see that P13 is what I refer to as the transitional phase of OIR, as it has a mixed phenotype of vaso-obliteration and neovascularization. This anti-angiogenic shift in VEGF expression in retinal vessel development appears to limit excess new vessel formation during physiologic angiogenesis in rumen mice, but cause excess pruning in OIR mice, leading to ineffective angiogenesis. I next began to investigate the effectiveness and safety of novel pro- and anti-angiogenic therapies that could potentially prevent ROP progression while avoiding systemic toxicity. So we asked the question, could early use of exogenous pro-angiogenic VEGF A165A during or right after vasobliteration restore angiogenic activity in the retina? In collaboration with Dr. Wang in UW Biomedical Engineering, we fabricated VEGF A165A microparticles incorporated in polylacticoglycolic acid (PLGA) polymer. PLGA is an FDA-approved biocompatible and biodegradable polymer. It provides sustained drug release, potentially reducing the need for repeat dosing, and it also avoids undesired systemic effects. The hydrodynamic diameters of the microparticles range from 2 to 10 microns with an average of 4.2 microns. In vitro studies showed a burst release of VEGF within the first 24 hours, followed by 74% release of VEGF from the microparticles by 72 hours. From this point, the release curve you can see reached a plateau in which only 2% of the protein was released from 72 hours to 144 hours. To find out what the VEGF levels were before microparticle injection, ELISA was done at postnatal day 13, P13, a day after oxygen exposure, and it showed that endogenous VEGF was 6-fold higher in OIR mice than rumen mice at P13. Well, this confirmed our findings that VEGF's androgenic activity is reduced or suppressed in OIR mice despite high levels, and that P13 could be a critical window for treatment in ROP. Following induction of OIR, mice received intravitreal injections of pro-angiogenic VEGF A165A loaded microparticles or MTPLGA microparticles to their right eyes on P13, which I call early phase 2. The left eyes of each mouse were controls. The microparticles were programmed to allow sustained release for about 7 days. In vivo retinal imaging showed earlier revascularization in the VEGF right eye microparticle treated mice compared to contralateral untreated left eye, empty microparticle right eye, and its contralateral untreated empty left eye. There was a 75% reduction in retinal avascular area, a 75% reduction in the retinal vein width, and a 90% reduction in retinal arterial tortuosity when compared to the untreated contralateral eye. We hope to further optimize the pharmacokinetics of VEGF microparticle fabrication and test the efficacy and toxicity of higher doses of VEGF A165A microparticles. Seeking a non-toxic treatment for later in phase 2 OIR, I asked the question, can vitamin D be used as an anti-angiogenic treatment in ROP? Dr. Shabani's prior research had noted that IP calcitriol, the active form of vitamin D, had strong anti-angiogenic properties in the retina. We confirmed this using my in vivo retinal imaging to show that IP calcitriol had more avascular areas, the yellow star, than the vehicle control, but the mice had growth restriction and high serum calcium levels indicating hypercalcemia. I then reached out to Dr. Hector De Luca, a renowned vitamin D expert who provided topical eye drop formulation of calcitriol. We decided to try it. These P24FA images show modestly increased avascular areas with low-dose topical calcitriol eye drop in the treated OIR mice compared to the vehicle controls without causing any systemic toxicity. So my 5-year NIH NEI from the National Eye Institute KOA grant studies the efficacy and mechanism of dual therapy of intravitreal proangiogenic VEGF A165A microparticles for early treatment of ROP and topical calcitriol for late treatment of ROP in restoring the vascular, structural, and functional OIR phenotypes. So, I believe that a retina is a window to systemic diseases because the human circulatory system is all connected, and retinal vessels are actually in vasculature in the body. Therefore, many systemic diseases have ocular manifestations that show up in the retina remote from the original organ. The optically clear medium of the cornea and lens allow visualization of the retina, which has been underutilized in bench and clinical translational research to understand systemic diseases in the brain, lungs, gut, and kidneys. So, in my research, I have correlated retinal vascular injury with acute lung injury and kidney injury in mice with OIR following in vivo imaging. Rumen mice have normal lung and kidney architecture. However, the OIR mice showed lungs with alveoli under inflation, thickened pulmonary epithelium with pulmonary vascular congestion that showed also increase in total inflammatory cells and protein levels in the bronchoalveolar lavage fluid ball, and this compared to Rumen mice. Kidneys of OIR mice showed signs of inflammation as well, with vascular engorgement, glomerular thickening, and renal tubular infiltration. All this from the same level of oxygen that had caused retinal damage similar to ROP. Hypoxic ischemic encephalopathy, HIE, from perineal asphyxia in term and near-term infants causes long-term disabilities, but HI-related retinal vascular injury has not been characterized. I collaborated with Dr. Senzeg at UW to study retinal imaging in the mouse model of HIE and also studied the efficacy of 7,8-dihydroxyflavone 7,8-DHF, a TRKB agonist, and neurotrophin in reversing the injury, if we saw any. Black 6 mice at P9 received unilateral left carotid artery ligation followed by hypoxia exposure to induce HIE. Using fluorescein angiography, we found that the naive control eyes raised in Romer had normal caliber vessels. The arrows show veins in blue, arteries in red, and collateral vessels in white. Mice with HI showed retinal artery and vein dilation as well as collateral vessel formation at 2 weeks and 4 weeks post-exposure in ipsilateral eyes. There were no collateral vessels seen in the naive control mice. The retinal injury was rescued by 7,8-DHF treatment. This is a closer look at the shortened collateral vessel in the ipsilateral eye following hypoxia ischemia. The graph here shows that the collateral vessels were restored by DHF treatment and were indeed caused by HI and not carotid ligation. Well, this establishes that ischemic retinal injury does occur in HIE, and the potential for retinal vascular monitoring as a biomarker for HIE and other systemic diseases is a great possibility. Future directions of my lab include studying the complex mechanisms of ROP beyond abnormal vascularization to include inflammation and VEGF dysregulation in ROP and other neonatal diseases such as BPD, IVH, NEC, and AKI. We believe this will help inform a more integrated approach to providing gentler clinical care in premature babies and direct safer therapies. So I began an extensive literature review of the complex interactions between angiogenesis and inflammation in neonatal diseases beyond ROP. We showed prolonged microglia activation in OR mice, and this suggests abnormal peripheral blood macrophage activity. In this review article, we explored the role of macrophages in both angiogenesis and inflammation in ROP, BPD, AKI, NEC, and IVH. The naive macrophages differentiate into pro-inflammatory M1 and anti-inflammatory M2 macrophages, and we have identified that an M2D subset are specifically involved in angiogenesis. Next, we explored how integrins regulate cell adhesion and migration, as well as VEGF signaling to modulate inflammation and angiogenesis in ROP and other neonatal diseases like bronchopulmonary dysplasia, acute kidney injury, necrotizing enterocolitis, and intraventricular hemorrhage. Then, we reviewed the endothelium as a platform for angiogenesis and inflammation in ROP and other systemic diseases, since VEGF ligand binds to VEGF receptor 2 in the endothelium, leading to endothelial cell proliferation and vascular permeability is increased. Why is all this important? Without the normal vascularization and development of the retina, one would not fully appreciate the beauty of that butterfly on the cherry blossom in spring. One may say, but the incidence of blindness from ROP is only 2%. Well, for the one infant with ROP, that incidence of blindness is 100%. In summary, my OR research expanded the ROP phenotype beyond abnormal vascularization using both retinal imaging and histology to include long-term structural and functional abnormalities. So, Oxygen should indeed be used judiciously in infants with developing vital organs. ROP diagnosis is subjective, and this could delay sight-saving treatment. We have shown that our quantitation of retinal artery tortuosity could be a more reliable objective biomarker of ROP severity and monitoring. ROP is a biphasic condition, and we have shown that P13 in the mouse represents a transitional phase in ROP, corresponding to about 31 weeks PMA in the infant, which may be a critical window for ROP treatment. We showed the feasibility of using VEGF microparticles as early treatment of phase 1 ROP to revascularize the retina, and the potential of topical calcitriol in phase 2 ROP to reduce neovascularization without systemic toxicity. We have also shown that in vivo imaging could be a window to study other systemic diseases in children with brain, lung, and kidney disease, as well as adults. My lab at University of Rochester will continue this bidirectional bench-to-bedside research using retinal imaging. I am very excited to explore new collaborations from UR's multidisciplinary expertise. I believe that for research to be meaningful, it needs to be beneficial to all human lives and have a global impact beyond our borders. So, we hope our findings can be applicable not only locally, but globally to resource-limited areas to improve health outcomes. I would love to acknowledge research support from the University of Rochester, New York, my NIH KOID grant support from the National Eye Institute, and prior research support from UW Department of Pediatrics and Macpherson Eye Research Institute Retina Research Foundation Gamewell Professorship. Many thanks to my research lab assistants over the years who have helped in bringing my ideas to life. I have been blessed with many mentors and collaborators along my career path, and I am very grateful for the opportunities they have presented to me with their guidance, resources, and most of all, the gift of their time and support. I hope to be the same kind of mentor to young clinicians and scientists I am blessed to meet and serve as I continue to grow as a scientist, clinician, and educator. Thank you very much.